Ladies and gentlemen, we'll keep to our feet and we'll observe the national anthem for Uganda and the East African anthem. I will ask our distinguished guests on the podium to take their seats. I will ask our delegates to also take their seats. Allow me to invite to the podium Dr. Olaro, Director General Health Services with the Ministry of Health. Allow me to also invite to the podium the Executive Director for SEHAD, Ms. Fatia Chiange. All protocols observed. Good afternoon, ladies and gentlemen. Good afternoon, ladies and gentlemen. Our chief guest is here. We can do better than that. Good afternoon, ladies and gentlemen. It's a privilege to be before you this afternoon. Once again, my name is Priscilla Regina Manoga, Masters of Ceremony for the Uganda National Conference on Health, Human Rights and Development 2025, being hosted starting today and over the next 3 days. And we are here converging under the theme, Right to Health, and the purpose mainly is to bridge the gaps across sectors to achieve equitable health, and this is for all. Before we embark on the afternoon's program, ladies and gentlemen, allow me in a special way to recognize the Right Honorable Prime Minister of the Republic of Uganda, Honorable Robina Nabanja. You're most welcome. Allow me to also recognize our leaders from the Ministry of Health. We do have the State Minister for Primary Health Care in Uganda, and that is Honorable Margaret Mohanga. You're most welcome. We also do have Dr. Charles Olaro, Director General, Health Services under the Ministry of Health. We also do have our partner, SEHAD. The Executive Director is before us, Ms. Fatia Chiange. Our global partners are in the room, World Health Organization, Ms. Cole, you're most welcome. Right Honorable Prime Minister, before you we do have the Ministry of Health, we do have World Health Organization representative to Uganda represented, we do have honorable members of Parliament, we do have the Executive Director, National Planning Authority, we do have the Ministry of Finance Planning and Economic Development. Right Honorable Prime Minister, we also have today in this room representatives from government ministries, departments and agencies. These include Ministry of Education and Sports. We do have representatives from the Ministry of Water and Environment. Ministry of Finance Planning and Economic Development is represented. Ministry of Gender, Labour and Social Development. We also do have the Ministry of Local Government. The Ministry of Transport and Works is in the House. The Ministry of Agriculture, Animal Industries and Fisheries. We also do have the Ministry of Trade, Industry and Cooperatives. Right Honorable Prime Minister, the judiciary is also well represented. represented in the room this afternoon. Local government and Ministry of Health, Parliament, Equal Opportunities Commission, and Uganda AIDS Commission, as well as young leaders and university leads. That being said, as we look to the right to health, bridging gaps across other sectors to achieve equitable health to all, Honorable Right Prime Minister, before you, we have had distinguished panels to discuss some of the key subjects for this conference. Our first key panel discussion was covering the state of social determinants of health and need to address the complex web of social, economic, environmental, and political factors that do impact health outcomes. And through that, we realized that multi-sectoral castle issues do affect the right to health for all Ugandans. We're talking about the state of roads, we're talking about unemployment, we're talking about the wage bill, we're talking about gaps in integration and policies, to mention but a few. I know that these are of major concern for you as the leader of government business. We also had a session that was looking to the nexus between health, human rights, and development for urgency in terms of addressing the underlying determinants of health. And those were also well catered for. The determinants were mentioned by our panelists, and they definitely show us that there's a lot to be done if only we could all join hands and forces and efforts and budgets and fundings to be able to achieve equitable health for all. That being said, yesterday we had a pre-conference where we had young people convening together and putting their minds together on what they thought and believed was the right to health and how they believed bridging gaps across sectors could achieve equitable health for all. Ladies and gentlemen, our distinguished guests, allow me to invite Sherina from right here, right now, to share with us what transpired in that pre-conference and also share with us the declaration from the Youth Town Hall. Sherina, you're most welcome.
Protocol observed. Good afternoon to you, everyone. Yes, my name is Nikpam Sherina, and part of the Youth Advisory Committee. Also a trained menstrual health and management trainer. Sorry, I'm just being interrupted a bit. Okay, let me get to it. Okay. Before I submit this declaration to everyone, I'd like to really appreciate our leaders for the great work that they're doing out there for the young people, and we acknowledge your efforts and every initiative you're putting in place to ensure that young people are supported the right way. We of course recognize the Youth Livelihood Program that was launched in January 2014 that is supporting the unemployed and the school dropouts and the young people living with disabilities, plus the young people living with HIV. We also see your efforts in the PDM and the UPE and USE supporting young people, so we appreciate. And this is what the young people have to declare. The Kampala Declaration on Youth Priorities adopted at the Youth Town Hall, Mistil Hotel, Kampala, on the 2nd of September 2025. We are the young people of Uganda across regions with various life experiences, career paths, diverse backgrounds, communities, and realities gather in Kampala under the theme of Power in Conversation, Youth and Leaders at the Accountability Table. We are the generation most impacted by policy choices made today and generation most ready to lead solutions. Acknowledging the 63.5% of Uganda's population is under the age of 25 as per the National Population and Housing Census 2024, we recognize both the opportunities and potential are invested and respected, Uganda can harness a powerful demographic dividend. If neglected, the nation faces a lot of generation and style development. With 77% of us under the age of 25, we see ourselves as a source of strength and not a threat when our health, work and dignity is supported and invested. We all win and the country wins. We recall Uganda's commitment in the Constitution of Uganda, National Development Plan NDP 3 and 4, the African Union's Agenda 2063, and the Sustainable Development Goals. We reaffirm our right as young people to health education, empowerment, dignity, and participation. Our priorities and asks are universal youth health access, establish comprehensive youth-friendly health services in every district, providing the contraceptives, mental health support, and the safe spaces for all young people by 2027. End teenage pregnancy crisis. Implement a fully funded national strategy with clear accountability measures to reduce teenage pregnancy from 24% to below 10% by 2030. Including comprehensive sexuality education and community support programs. Expand national health coverage, increase national health insurance coverage from 25% to 80%. And by 2030, prioritizing with access to affordable healthcare services. And fourthly, guarantee quality education for all. Ensure completely free, equitable, and quality education with measurable improvements in retention and completion rates, eliminating all hidden costs and barriers. Number 5, double education investment. Increase education financing to 979 million by 2025 as recommended by the World Bank, with transparent tracking of fund allocation and impact. Close the youth employment gap, that is a very serious issue. Create 700,000 quality jobs annually for young people through targeted economic policies, skills, training, and private sector partnership with clear employment targets. Reform youth economic programs, overhaul the Youth Livelihood Fund and EMYOGA programs with complete transparency, accessibility, and accountability to ensure funds reach their intended beneficiaries. Number 6, institutionalize youth leadership, mandate meaningful youth representation at a minimum of 30% in all decision-making bodies, from local councils to national parliament, with voting rights and budget allocation authority. Number 9, ensure digital equality. Provide affordable internet access and comprehensive digital literacy training to all young people, especially in rural areas, to bridge the digital divide by 2028. And lastly, guarantee inclusive participation. Establish specific quotas and support systems ensuring marginalized groups, including girls, refugees, sexual minorities, persons with disabilities, and rural youth have equal voice and representation in all programs and governance structures. Our commitments as young people, we pledge to remain engaged partners in shaping Uganda's development, use platforms like the town hall and other policy spaces to track results and demand for accountability, champion integrity, innovation and solidarity, and collective action with our communities, lead all voices and include marginalized groups and leave no one behind. Bridge the digital divide and information divide, share tools, resources, and strengthen youth advocacy. Work collaboratively action, we demand concrete, time-bound actions within 30, 60, and 90 days on these priorities. These commitments must be documented, tracked, and implemented transparently with youth engaged in monitoring. The adoption in Kampala, Uganda on this day of 2nd September in the presence of the representatives, leaders, and partners. Thank you so much, everyone.
A round of applause for Sharina. The declarations were 10, were made their own commitment to ensuring that there's a right to health equitable for all. However, they put some conditions there. 30 days, 60 days, 90 days. I believe the leader of government business has had those conditions. I'm not sure how possible those are because we're in an electoral cycle, but I also know that government, ever so and again, is doing the very, very best to ensure that they meet the needs of each one of its 45.9 million citizens. Now, as we do continue on, we get to look at another presentation that is going to be coming in from World Health Organization. As we continue to unpack today's theme this afternoon, right to health, bridging gaps across sectors and achieving equitable health to all and for all, it is very essential that this conversation is anchored on evidence and driven by global perspectives. Because we're not in this alone. We're not just Uganda standing aloof. In Uganda, we belong to the East African community, we belong to the African Union, and then we belong to all other global bodies out there. World Health Organization being one of those that has consistently emphasized that up to 55% of health outcomes are shaped not within hospitals, but by the social determinants, the environments in which we live, the environments in which we learn, the environments in which we work, and the environments in which we grow. Now, these include access to things like clean water, basics like decent housing, fair employment, education that has been mentioned in the Young People's Declaration, transport, and social protection. But these factors are unequal. Health inequalities are widened by and large. So to shed more light on this urgent matter and to deliver powerful to action from World Health Organization's latest global report on social determinants of health equity, we are honored to have with us Ms. Kiha Cole, the team lead with the health systems, and that is with the World Health Organization. However, this afternoon she is representing the World Health Organization representative to Uganda, Dr. Kasonde Winga. Ms. Cole, you're most welcome.
Good afternoon, everyone. Let me send, first of all, the greetings from the WHO country representative, Dr. Kasonde Winga. She's currently out of the country, and I have the great honor and pleasure to address the remarks on behalf of her today. The Right Honorable Prime Minister, the Honorable Minister of State for Primary Health Care, Director General of Health Services, senior government officials, members of parliament, representatives of the UN agencies and international organizations, health service users, health rights advocates, service providers, researchers, policymakers, legislature, academia, media, donors, and community representatives. All protocols observed. Let me begin by expressing my sincere gratitude to the organizers, the Ministry of Health and Food, of this important conference on health, human rights, and development, and the opportunity for WHO to address today to you and speak about the recently published WHO World Report on the social determinants of health equity. I commend you for spotlighting a topic that is essential to national development and must be integrated into planning and implementation, ultimately to improve the health outcome of the Ugandan population. This report responds to a request by the 74th World Health Assembly, that was in 2021, a request by 194 member states, including Uganda, tasking the WHO Director General to provide an update on the social determinants of health, its impact on health and health equity, the progress that has been made, and key recommendations for the future. I invite all of you to peruse through this report that you can find online on the WHO website. In the time that I have been giving, I won't do justice to the around 250 pages of report summarizing the latest evidence. However, there is also, for those who are time-constrained, a very concise executive summary provide the key information. The report really presents the evidence-based strategies and policy recommendations to guide governments, civil society, and international organizations in building a just and equitable health system. It draws on global evidence, examples, country case studies to demonstrate the positive impact of interventions that address social determinants. We have already heard in the morning, and we are all aware, health outcomes and inequities are profoundly shaped by the social, economic, and environmental conditions in which people are born, live, and work. And these conditions are in turn influenced by broader political, cultural, and economic forces. Uganda's National Development Plan, the NDP4, reaffirms the government's commitment to improving household incomes and quality of care. And one of its strategic objectives, as you are aware, is to enhance human capital development across the life course. We know that many of the social determinants of health are not directly within the remit and the responsibility of the health sector. Most of the social determinants of health are without health. They lie outside the health sector, and that's important to recognize, and it underlines the critical importance of the multi-sectoral approach. And this very much aligns with WHO African Region strategy to promote health and well-being through coordinated actions across government sectors, civil society, communities, and development partners. Now, the Ministry of Health is now mandated to advocate for and support the integration of health-promoting policies and investment across sectors. What does that mean? How can we ensure that services are getting closer to where communities live? What are the barriers for certain population groups to access those services? Which interventions are suitable in order to promote more of the active involvement of people's health and well-being? And do we have the full pictures of what other sectors can do in order to influence the social determinants of health? All of these questions are critically important in order to advance the discourse towards the Sustainable Development Goals, particularly the SDG 3.8 on universal health coverage, meaning that every Ugandan has the right to access the services without financial hardship. In 2024, the Ministry of Health reviewed and analyzed around 20 Program Implementation Action Plans, the PIAPs, and 12 District Development Plans to identify and to document investments that impact key health indicators. And one of the key highlights is really that when we see across that nearly all of those PIAPs contain interventions that significantly influence the health outcomes. Ultimately, the Human Capital Development Program, which includes health education, gender, labor, social services, water and environment is especially critical to promote multi-sectoral collaboration to advance the noble goal of universal health coverage by leaving no one behind. Now, when we also reviewed the district development plans, the Ministry of Health also understood that many of those plans were very much in alignment with the program implementation action plans. However, budgetary constraints limited the implementation of planned intervention, underscoring the need for resource mobilization and strategic prioritization. The WHO report that now has been recently launched in May outlines 4 broad categories and strategies to address the social determinants of health equity. 1, address economic inequality and invest in social infrastructure and universal public services. Economic inequalities and inadequate access, let me stress here, the inadequate access to quality public services in areas such as health, education, social protection, transport, and housing are major drivers of health inequities. 2, overcome structural discrimination. Structural discrimination is discrimination which occurs systematically across society and is embedded in prevailing cultures, legal mechanisms, and economic structures. 3, manage the challenges and opportunities of climate change and digital transformation in ways that promote health equity. Climate-related actions addressing the social determinants of health equity must be intersectoral. For example, measures to reduce pollution through stricter environmental regulations, expanding public transport, and promoting sustainable agriculture practices that enhance food security and nutrition while benefiting the rural population. Digital technologies and big data can improve health and social care delivery and outcomes, but their effectiveness, again, is very much in order to support health equity, depends on how they are deployed. And ultimately, let us not forget, information is an important determinant of health in its own right, with misinformation and disinformation growing mediators of health outcomes. The last one, number 4, is establish government's arrangements that enhance the coherence and impact of action. National governments, international organizations must support and collaborate with local governments, communities, and civil societies in their efforts to address the social determinants of health equity. Empowering local governments, civil society, and communities is crucial for addressing health equities, to develop local solutions based on the contextual factors. The report outlines a set of 14 key strategic recommendations, and they offer also, for today's conference and for Uganda, a roadmap to advance Uganda's efforts and contribute to achieving the Sustainable Development Goals. These include, for example, reducing economic inequality, investing in social infrastructure, improving income security, tackling structural discrimination, addressing climate change and digitalization, empowering communities, ensuring equitable access to health care, and strengthening governance and data systems. Now, to realize goals from these recommendations, government must create sufficient fiscal space for investment. Efficient and extensive and progressive taxation can be a powerful tool for revenue generation to support actions on the social determinants of health. Given the cross-sectoral nature of the social determinants of health, coordination, we have heard it already earlier, coordination of planning, coordination of implementation, and coordination of monitoring and evaluation at the highest level of government is essential. I therefore commend the organizers for recognizing this critical governance priority and inviting the Right Honourable Prime Minister as our chief guest. Right Honourable Prime Minister, allow me to emphasize that the success of initiatives addressing the social determinants of health relies heavily on the direct support and leadership from your esteemed office. The WHO report on social determinants of health equity provides a timely and strategic foundation for advancing this agenda. The report concluded with the statement, equity is a political choice. Universal health coverage is a political choice. WHO remains committed to fostering global and national policy norms and standards, supporting obviously the evidence generation, building investment cases, convening diverse partners, and strengthening the capacities of the social determinants of health. We will also continue to advocate for actions on social determinants in multilateral forums, facilitate knowledge sharing among member states, and support the evaluation through monitoring frameworks and equity assessment tools. And with that, I thank you very much for your attention.
Another round of applause for Ms. Cole. Those recommendations come in time, especially for the different sectors, public and private, represented in this room, to be able to then integrate them accordingly to your strategies, your structures, and implementation plans and programs or initiatives that you have in the works. We thank you, World Health Organization. Now, our program is going to be running as follows. We are going to be hearing from the Ministry of Health, and then thereafter we'll be hearing from our chief guest, the Prime Minister for the Republic of Uganda, who will then give her opening remarks, and then she'll do us the distinguished honor of opening this conference officially, launching it officially, and then thereafter we'll also be conducting special ones for different MDNs that have contributed towards the realization of equitable health in Uganda. Thereafter, we'll go into our breakaway sessions, so please do bear with us. Ladies and gentlemen, our chief guest this afternoon is none other than Right Honorable Robinah Banja, having been appointed the Prime Minister and lead of government business in the Parliament of Uganda, and this was on the 8th of June 2021 by His Excellence Yoweri Kaguta Museveni, making her the 11th and first female Prime Minister since Uganda's independence. So we have a lady before us who is a lady of fasts. If I do remember correctly, when she had just gotten her appointment, there was a social media, a video that went around on social media of her in her compound doing her workout. And many of you were like, hey, a whole Prime Minister, yes, the whole Prime Minister putting physical health at the forefront of the agenda of government business. And so those of you that are not doing your physicals, please learn from the Prime Minister. We also do have Honorable Margaret Mahanga, who's the State Minister for Primary Health Care, and this is to the Ministry of Health. She does play a very significant role in advancing healthcare, and this is also accessing policies across the nation. So for the other discussions that we're talking about policies, they definitely I'm addressing them to the right ministry and the right persons. Now she will be giving us a keynote address also on the multi-sectorial approach to realizing equitable health, and this is for all Ugandans. Ladies and gentlemen, without further ado, allow me to invite Dr. Laura Charles, Director General of Health Services at the Ministry of Health, to be able to then introduce our next speaker accordingly. Doctor, you're most welcome.
The Right Honorable Prime Minister of the Republic of Uganda, Honorable Robinah Banja, the Honorable Minister of Health, Honorable Margaret Mugisha, who is the Minister of State for Primary Health Care, the representative of the WHO, the Executive Director of SEHAT, all invited guests, ladies and gentlemen, in the interest of time, let me stand on the already existing protocol. My role this afternoon is a brief one, Right Honorable Prime Minister. This meeting is co-hosted between the Minister of Health and SEHAT, and the Executive Director of SEHAT is amidst us. Look, Madam Fatia Chiande, she could be outstanding so that we can recognize for her. This is our second conference. It's following the one which we had in 2023. And specifically, Right Honorable, we looked at the theme of social determinants of health. And we are looking at that the health sector and the health contributes only to 20% of the health and well-being. The other 80% is contributed by the other health sector. So we saw that it would be desirous that we move health outside the health sector, and so that people can be able to make contributions. And that's why the Director of Ceremonies has indicated that we have got a varied members in attendance. Our guest of honor, I will seek your indulgence, and I think it will be appropriate that I give the other co-chair of the two Filipinas to speak before I invite the Honorable Minister of Health. Co-chair.
Thank you so much, Director General, Right Honorable Minister, Right Honorable Prime Minister, Honorable Minister of Health, Primary Health Care, the WHO, the Board of Directors and Trustees of Center for Health, Human Rights and Development, all representatives of government institutions, development partners, we have some embassies here, and all delegates, protocol, I stand on the protocol already established. Because Dr. Laro has introduced the conference to you, perhaps I want to appreciate the Ministry of Health for working in harmony and closely and opening their doors to civil society like us because of our shared goals and objectives of realizing equitable health and human rights for all people with a strong focus on those that are most vulnerable. So I'll probably just introduce this organization to you. The Center for Health, Human Rights and Development was established 15 years ago here in Uganda. It is a mainstream legal and human rights organization that addresses social injustices, inequalities, and health rights violations within the healthcare system, but also across other sectors which impact on the health outcomes of girls, women, and other vulnerable communities. We at CEHAD envision a society in which social justice and human rights in health systems is realized. Also, our mission is to advance health rights of vulnerable communities through litigation, advocacy, research, empowerment, as well as social movement building to ensure that we have equitable health and human rights for all people. Our key focus areas include health system strengthening, sexual and reproductive health and rights, communicable diseases, non-communicable diseases, neglected tropical diseases, mental health, climate change and environmental justice, as well as digital transformation. Right Honorable Prime Minister, we serve the most vulnerable people that include women and girls, youth and adolescents, children, and on this note, I'm very passionate about children. One of our programs is a legal aid program for health rights violations, and the bigger number of our clients at CEHAD are children who face sexual violence. We also serve persons with disabilities, people living with HIV, minorities, elderly, and survivors of sexual violence, torture, and conflict, and inadequately served populations, as well as refugees and forced migrants. We do have an ambitious 10-year strategic plan, Right Honorable Minister, and we have a special request that this organization today is requesting you to honor us by officially launching our 10-year strategic plan, following sharing with you just a summary of what this organization does for equitable health and human rights for all people, giving special focus on the vulnerable communities, and working collaboratively with the government, specifically Ministry of Health and other sectors, to ensure that health is given attention across the whole society, across all the sectors of government and civil society, private sector, and all other key players. Thank you so much, Dr. Lara, for giving me the opportunity. I want to, in a special way, to again thank you sincerely, Right Honorable Prime Minister, for honoring this important event, and of course, our Minister of State for Primary Health Care. We think this is important, and we think if the recommendations, then the actions that come out of this conference are honored and implemented and financed, we are likely to accelerate our progress towards UHC, towards the rest of the goals for 2030, but most importantly, our Vision 2040. I thank you.
Yes, I appreciate the Executive Director. Right Honorable Prime Minister, I want to thank you for coming amidst your busy schedule. Let's clap for Right Honorable Prime Minister. I also want to thank Honorable Margaret. She has been with us since morning. She's really endured and been able to be resilient Minister of Primary Health Care. Thank you, Honorable. As I conclude, Right Honorable, I have one call that we want to call you to champion the aspect of self-care, both in government and outside government, so that individuals, families, communities can take care of themselves, either in the presence or absence of a health worker. Dr. Mugai said that she's already a champion, so it means that you have accepted. Thank you very much. At this point in time, I want to invite Honorable Margaret Muhanga, Honorable Minister of State, to address us, and thereafter invite our guest of honor to officially open the second conference on health, human rights and development.
Our chief guest, the Right Honorable Prime Minister, Honorable Robin Anabanja, the honorable members of Parliament here present, senior officials from government departments and agencies. I hope we have religious leaders as well, cultural leaders, health development partners, civil society organizations, the academia, and the private sector. You are all most welcome. It is my pleasure today or this afternoon to address you, especially on this important ceremony, the second biannual Uganda National Conference on Health, Human Rights and Development. Today we are actually building on the momentum of the UCHD of 2023, because this is the second meeting, and it's proof of what can be achieved when government, civil society, the citizenry, even the fourth estate commit to work together to advance the rights to health for everybody. This conference is unique. It's really a unique platform where duty bearers and beneficiaries of healthcare come together and confront realities of health in Uganda that extend far beyond the hospitals and clinics, into our homes, our schools, the markets, the farms, and even our workplaces. Right Honorable Prime Minister, you missed the keynote address from Professor Ben to Lord Bishop. He raised a lot of pertinent issues that health starts with us. Your health is your responsibility. That people have relegated their responsibility to say, oh, government didn't do this, so we went to the hospital, we didn't find medicine. I always tell people wherever I address meetings like this, that the Ministry of Health has a burden of disease which are preventable at 75%. That means if we are more careful, avoid these diseases, live in cleaner environments, work out our bodies, would reduce the disease burden and wouldn't have a lot of people coming to our hospitals. But because we have not taken that personal responsibility, sometimes it's out of neglect, we end up with diseases, and the professor stated these issues and highlighted them. We are here as providers and consumers of this precious commodity called good health. Universal health coverage is really a fundamental right. Everybody has a right to health. But as government, we have critical obligation of implementing reforms to ensure universal health coverage by 2030. Great progress is being registered in this direction as we strive to achieve our national development aspirations under the Vision 2040. We have invested in expanding health infrastructure, strengthening human resource for health, and rolling out essential health service package. And I'm sure you must have heard that we also increased the pay for the health workers so that our people can be healthy. I don't think it's called positive discrimination, because these people are working on our health directly, so we need them more. The government of Uganda therefore recognizes that health of our people cannot be addressed through fragmented intervention, but rather integrated services. And an integrated service system will require that the Ministry of Water provides clean water to the population, that the Ministry of Agriculture reaches out to the farmers to grow the right crops and also give them proper nutrition. Also to strengthen food and nutrition systems through our Ministry of Agriculture, and also affordable diets that can reduce malnutrition. These are the preventable conditions that I'm talking about. The Ministry of Transport must improve and strengthen our road system so that our ambulances carrying pregnant mothers reach facilities in time. So it's indeed a multi-sectoral approach that we are taking as a ministry with other ministries to make sure we have national health coverage. The Ministry of Education must empower children or our learners with skills and vital knowledge on sexual and reproductive health to avoid teenage pregnancies, children going out of school. All this is work of the Ministry of Health. This will strengthen our systems and people will know what to do at the right time. I would like to acknowledge the leadership of CEHURD, which is CEHURD, and other civil society partners who continue to champion community voices, document life experiences, and also push us for accountability. Civil society brings out the realities of people, whether it is a pregnant woman struggling to access antenatal care, a youth facing unemployment, or a family living within a safe water catchment. But as Ministry of Health, our intention is to have everybody access a health facility within 5 kilometers, which we are at 90%. And soon we shall have that done. In conclusion, we need to really live here after these 3 days with practical commitments that speak to Ugandans who have not been privileged to make it here. They should get it from the state. That no mother should die while giving us a life. That no child will miss school because of malaria or malnutrition. That no adolescent is denied accurate information about their bodies. that no one is left behind due to their background, due to their gender or income. And on behalf of the Ministry of Health of Uganda, I really welcome you to this UCHD 2025 and commit to support your resolutions from this conference. And I will be your ally in supporting them. It is now my singular honor and pleasure to invite the pragmatic and dynamic Prime Minister, the Right Honorable Governor Uganda, to come and open this meeting officially. Right Honorable, you're welcome.
The Honorable Minister of State, Health, Primary Health Care, the Honorable Members of Parliament, I'm told you are here. Our partners, representatives from ministries, departments and agencies, I mean our technical people, all delegates, ladies and gentlemen, allow me to bring you greetings and parental love from His Excellency General Yoweri Museveni, the President of the Republic of Uganda. He's aware we are here, deliberating on this issue. I am pleased to join you this afternoon for the second Uganda National Conference on Health, Human Rights and Development of 2025. I wish to thank the Ministry of Health and your partner, the Center for Health, Human Rights and Development, for inviting me for this very important conference. I have learned that this is a biannual gathering which started 2 years back, that is in 2023, and I'm told this has become a unique space for honest discussion, reflection, charting bold visions, and of course recommitting to the fundamental truth that health is both the right and the cornerstone for development. The theme for this conference, the right to health, bridging gaps across sectors to achieve equitable health for all, could not be more timely, especially for my office, which has the sole responsibility to coordinate all government ministries, departments and agencies to deliver on the country's mandate. I mean, our vision of 2040, the goals and programs. For many years, government has been promoting the role of multi-sectoral approach as a critical strategy for advancing the whole of society development. And this is well stipulated in most of our national policy frameworks and strategies. I see this conference as an important initiative for accelerating collaboration for greater impact of all our interventions. You all know that good health does not come from hospitals and medicines alone. It is born out of the social, cultural, environmental, and economic conditions in which we all live. The World Health Organization reminds us that health systems account for only 20% of the health outcomes. Only 20%. The rest is determined by the social determinants of health. And these include education, skills development, income security, employment, housing, living conditions, access to safe water, sanitation, nutrition, and food systems, social and cultural norms, including gender roles, stigma and harmful practices, and the climate and environmental that sustain us. These social determinants are not abstract ideas. They are the lived reality of millions of our people. Besides our high fertility rate, 1 in 4 Ugandan girls aged between 15 to 19, I'm told, and this is real, that they are already pregnant or a mother, and this is according to the Uganda Demographic Health Survey of 2022. And that although our maternal mortality ratio has declined, that we are still far from meeting the target of 70 per 100,000 live births. I take a note that we are still behind on younger people's health and well-being, including on indicators for sexual reproductive health. Honorable Minister, ladies and gentlemen, like many African countries, Uganda continues with the challenge of unemployment, harmful social and cultural practices, stigma around reproductive health, and gender-based violence. We still have floods. Recently we had a problem around Mount Elgon. We have drought around the Karamoja sub-region, and the changing disease pattern driven by climate change, which has undermined agriculture, and of course, this has worsened the food security. The country still faces a double burden of communicable and non-communicable diseases, with hypertension affecting over a quarter of adults, and 35% new cancer cases were registered in the year 2022. These challenges cannot be fully addressed by one sector of government. Uganda has demonstrated that multi-sector collaboration works. I repeat this for you to note. Uganda has already demonstrated that multi-sector collaboration works. My office, under the SDG Coordination Secretariat, ensures national level alignment across ministries, departments, and agencies, and has been open to the contribution of non-state players in advancing the SDGs in this part of the world. Uganda AIDS Commission has successfully integrated HIV responses across health, education, gender, and the Ministry of Finance. I'm aware that the Ministry of Health has championed an inter-ministerial mechanism where permanent secretaries meet quarterly to find solutions for addressing teenage pregnancy. And they have also implemented a teenage pregnancy surveillance and response model jointly with partners like Schedule, exemplifying government CSO's collaboration. The Ministries of Agriculture, Ministry of Health, Water and Environment are jointly addressing nutrition and climate-smart agriculture, while the civil society works with local governments to improve community-based service delivery. As you can also see, together we have lessons which we are learning from sister countries. I'm reliably informed that in Rwanda, they have a community health worker system of governance that delivers universal health coverage. I'm also reliably informed that in Rwanda, you know that one, eh? That one. Yes, in Rwanda, that is West Africa. They have aligned the 9 governments and donors to accelerate family planning. So together we have lessons from those sister countries. And this can help us to reinforce the goals of Uganda Vision 2040 and the 4th National Development Plan, which places human capital development and inter-social sector collaboration at the center of transformation. Allow me to acknowledge the youth conference that preceded this conference. Uganda's young people are not just leaders of tomorrow. I'm told they are leaders of today. I'm told, reliably informed with statistics, that with 73.2%, not 80 as reported by the youth who gave us a report here, it's not 80, of our population are under the age of 30. And we want them to participate meaningfully in the country's development by shaping our planning and participating in governance processes and the execution of our government programs. Their demand for accountability in health, education, and for jobs must guide our national priorities. They remind us that transformation requires patience, boldness, and above all, shared vision. We must ensure that their energy, they are still energetic, innovation and demands remain at the heart of Uganda's health equity agenda. My office holds a unique convening power and a coordination responsibility. I therefore commit that government will continue to strengthen my bilateral or my sectoral collaboration for health through our national platform. The platform already exists. You know, this platform brings together all sectors to contribute to the health outcomes. And this includes, but not limited to, Ministry of Education, Ministry of Finance, Ministry of Gender, Ministry of Health, Ministry of Water and Environment, Agriculture, Ministry of Trade, Transport, Judiciary and Local Government. This platform will continue to facilitate a collective approach to finding solutions to address persistent health inequalities across the country. This collaboration will strengthen the integration of health into all policies, plans, and strategies and budgets, ensuring a true health in all policies approach. We will mobilize resources for primary health care and other equity-driven programs to ensure that no one is left behind due to either geography, gender, and social status. We will continue to strengthen national data systems to monitor health, education, gender, and climate outcomes collectively. We will create structured platforms for youth, civil society organizations, and communities to contribute to policy design and accountability. And distinguished delegates, Uganda's path to equitable health and indeed for our sister countries will not be secured by only one ministry or sector. It will be achieved by collective action across all sectors. It is on this note that I want to salute the Ministry of Health, the Center for Health, Rights, Human Rights and Development, and the other government ministries, departments, and agencies, our development partners, academia, the civil society organizations, the private sector, cultural and religious leaders, and most importantly, our younger people of Uganda, whose voices continue to inspire us. Together we can deliver on Uganda's Vision 2040, the National Development Plan 4, the Sustainable Development Goals, and universal health coverage, which already articulate the critical role of multi-sectoral collaboration. We can together build a Uganda where health, dignity, and opportunity are shared by all. With those remarks, it is my honor to declare the second Uganda National Conference on Health, Human Rights and Development 2025 officially open. For all of
Keep the hand clap. And we have a number of awards and also the official launch of the strategic plan for the Center of Health, Human Rights and Development, which we would kindly request that you perform, and also after. Put your hands together for the official launch of the strategic plan by the President of the Prime Minister of the Republic of Uganda.
I'm going to wait for the trustees and vote.
Much obliged, my right honour.
strategic plan for
And the strategic plan for Prime Minister is under the 2025 to 2034. It's catering to health, it's catering to policy, and it's also catering to law. We will request your signature on it to confirm that indeed you have endorsed this strategic plan campus for equitable health and human rights for all. Ladies and gentlemen, a round of applause. The Right Honorable Prime Minister of the putting pen to this strategic plan. A round of applause for her. We also have Honorable Margaret Muhada with the Ministry of Health, State Minister for Primary Health Care. Also making signatory to this strategic plan. Ladies and gentlemen, allow us to also have Dr. Olaro putting a signature to the strategic plan. And you can avail us some copies to share with the team here. WHO is also signing this call, affirming that this strategic plan is indeed focused on human rights, the right to health, equity, and non-discrimination. Professor Ben Tuinovicha, you have transformed the mindsets of people in this room today. I know that you are part and parcel as a senior researcher. You've had enormous contribution to this. We'll also have the Sehat vote, putting signature. To the Ministry of Water and Environment. Let's have a representative from the Ministry of Water and Environment. They have spearheaded the water sanitation and hygiene program, which has been instrumental in advancing menstrual hygiene management and also enabling girls to remain in school. By strengthening both WASH and education, the Ministry of Water and Environment has contributed significantly to addressing key social determinants of health, as well as fostering equitable development. So to the Ministry of Water and Environment, thank you so much for a job well done. All right, the next Equity in Health Award is presented to the Ministry of Gender, Labour and Social Development, the representative from there. They are being recognized for their leadership in addressing poverty as a critical social determinant of health in Uganda. The Ministry of Labour, Gender and Social Development, through their Protection Directorate, as well as initiatives such as expanding social protection, the Ministry has advanced equity in health by supporting vulnerable populations. We don't have a representative? Okay. The Equity in Health Award goes to the Equal Opportunities Commission 2 for standing with and protecting the rights of people living with HIV, including the landmark 2023 judgment. Do we have a representative from the Equal Opportunities Commission? No. All right, Ministry of Health, Adolescent Health Department. The minister is also here. All right, so the Ministry of Health, especially the Adolescent Health Department, is being awarded this token as a pioneering quarterly interministerial engagement, bringing together health, education, sports, gender, labor and social development, local government and other stakeholders, the purpose of which is to address Uganda's high teenage pregnancy rates, and they've done a great job. And then the last one is going to the Parliamentary Forum on Non-Communicable Diseases. Do we have a representative of the forum? Yes, we do. Our Parliamentary Forum on Non-Communicable Diseases is presented to you for your leadership in addressing the rising burden of NPCs in Uganda. Through education, equitable investment, as well as inclusive health planning. The forum has strengthened the country's response to NCPs and promoted equitable health for all. Ladies and gentlemen, that brings all the awards that we have for this conference 2025. Now we're going to take a group photo with the State Minister. Let's start with the ones that have picked awards. If you have an award, Ministry of Water and Environment, Ministry of Gender and Development, Equal Opportunities Commission, Ministry of Health, Parliamentary Forum on Anti-Communicable Diseases, please come forth with your awards. And let's take a group photo. An acknowledgement of the milestones and your contributions to equitable health for all. All right, taking your positions. Taking your positions, let's have the media team capture that moment. Thereafter, Team Sehat, please go for a group photo.
Show documentation of enablers and barriers to access HIV services, but also conducting advocacy and community action for change, along with collaboration and empowerment of diverse CSOs and communities. So today, in this presentation, we showcase how community-led management and participatory activities strengthen health systems, enhance pandemic preparedness, and ensure equitable, rights-based access to care, and aim that really blends really well with the right to health. Today's theme, the right to health, and obviously bridging gaps across other sectors to achieve equitable health for all. Such as women living with HIV, adolescent girls and young women, and other vulnerable populations faced it rough in terms of disruption, services, and rights violations. So I see regional and global levels, but most importantly, document systemic barriers and propose solutions directly from community voices. We leveraged on a huge issue, a problem. We saw a dominating conventional top-down health systems strengthening, which leaves blind spots. In obvious words, it overlooks critical insights from the ground, from the community. And as I say it openly, it fails to adequately capture lived experiences of vulnerable populations or effectively adapt to emerging health crisis because we're not involving communities from the ground. And this gap compromises responsiveness, equity, and sustainability of health services, directly impeding the realization of rights to health for all. As an approach, or we would choose to call it methodology, collect both quantitative and qualitative data in its design. And in real time, in its approach here, we leverage on mobile application called ComeCare and participatory tools running out of our voices.
And Malaika, Sheila Malaika she's from harm reduction, she's a harm reduction coordinator, Alliance for Women, advocating for change. So, Malaika, of course, as Malaika comes in, I think, Shamim, you didn't also tell us who you are. We also need to know the person who presented to us.
Gentlemen, unfortunately, 7 minutes might not be enough. When I start speaking harm reduction for women, I become passionate. I need like the whole day. So I'm going to skip some of my slides and go direct to what harm reduction is. And I'll start with posing a question. What is harm reduction? A lot of us do not know what harm reduction is. A lot of us, when we talk about harm reduction, they think we are encouraging people to continue with a habit. A lot of people think if we talk harm reduction, we're encouraging people not to quit, if that is even a word. A lot of people think if we talk harm reduction, we are encouraging new people to start on a habit. But no, harm reduction is not that. Harm reduction is, as you hear it, reducing harm for a habit that you might have picked. Could be sex work, could be drug use, but now I'm emphasizing on drug use. Female sex workers who use drugs. They are punished, they're excluded. Nobody bothers about them actually. Everybody keeps telling people saying, why bother with those ones? They chose the habit. But it is not a habit that you choose. It's a habit that later becomes a disease. Drug addiction is not a habit that a person wakes up in the morning and they choose to take on and choose not to leave. Drug addiction becomes a mental health issue, and it needs a lot of support, a lot of intervention to get through it. And this is where harm reduction comes in, because harm reduction meets you where you are. We'll have people who are going to recover. I don't like saying that word, but it makes my explanation easier. Some people recover completely, some people will recover and relapse. To relapse is to go back to the habit. Some people may not go off completely, and those that don't go off completely are the most important ones here, because they are most at risk of getting blood-borne diseases. It's HIV, hepatitis C is very rampant in people who inject drugs, especially women, because of their intersectional vulnerabilities. It becomes too much. I wish I could go into the statistics, but the time will not allow me. They face all that, the stigma, criminalization, and now what makes it even worse is when police catches you, even if you're not using, but you are in possession, the harassment that you get is worse than the situation you're going through. And all these barriers, stigma, gender-based violence, even intimate partners, because they have boyfriends and husbands, they mistreat them. Because of all these hospitals, health facility personnel, if you go to a hospital and you're a drug user, female or male, they'll look at you as if you're Lucifer himself. Because, why does a person even wake up in the morning and they decide to use a drug? But like I said before, it is not a choice that a person wakes up in the morning and they make. We have people who are addicted to pharmaceutical medicines. they had an accident, and they are prescribed medication. I'll give an example of pethidine, if anyone here knows what pethidine is, or tramadol. Please allow me to kindly. So it is not a choice. Let's not judge these people. Let's not leave them behind. Let's give them all the support that they need. The time, I needed like the whole day. We have one powerful solution: medically assisted treatment. Now, we have 2 clinics for medical assisted treatment in Uganda. One is in Mbale, one is in Butarika. Those 2 treatment centers are quite a distance from where these people who use drugs live. And every woman who uses drugs that would have loved to go for treatment will tell you they cannot afford transport. Butarika is very far. You cannot walk to Butarika and back. You cannot afford transport to Butarika and back. But there is a medication called buprenorphine that is not a daily medicine, like the medicine that is given at those 2 treatment centers that I've mentioned. So it can be taken like once in 3 or 4 days, depending on your dose. And if we could have that in the community, so that a woman who feels stigmatized, who does not want, because we're women, people will say, that reason stigmatizes people and they will not even seek treatment, leave alone the transport. If we can have buprenorphine in the communities, where a woman will come to a safe space, let's suppose they come to a work, and they'll find a person they can be comfortable to speak to, get that medicine prescribed, take their medicine, go back home, come back after 3 days, I'm sure. And let you read my note, because I get passionate. No, not yet. Yes, so at our work, we have peer support, women with lived experience, women who have recovered. Yes, and now, this is a picture of women in a hotspot in Kiseni, women who use drugs, who inject drugs. And some of these women here have used and have quit, they have recovered, or they are on treatment. So they go back to their peers and talk to them and counsel them, encourage them to also seek treatment. This one here, Musao is educating a drug user on how to inject in safe spots on the body, because not every part of the body is supposed to be injected. If you inject badly, you get abuses and all that. So we do that in harm reduction. The NSP program, we give clean needle and syringes, and we also teach people how to inject in the correct way for those who are yet to recover. The same thing here. We also link to MAT services Through this work, we are proving that when women lead, communities heal. Okay, call for action. I've said all that I've said, but we still need support. If we have any health practitioners, policy makers, donors, community leaders, I'd like you to join us in this fight. Fund the programs at the centers of dignity and health, and advocate for laws and policies that protect rather than punish women. Because when we invest in women, we invest in healthier families, safer communities, and a more inclusive Uganda. Thank you.
Lower health facilities and communities to support supervision by the district health management team. For sure, it has yielded excellent results, as we shall look at. Many people have been talking about so many things that are raising a lot of emotions, but I want to remind you that actually what you should take from here is that the others will raise emotions, but this one kills. This one does what? Yeah. Go to the 10 causes of death. Malaria could be number 1, number 2, number 3. So we have to take it up seriously. So, at the background, we are saying bridging gaps at low health facilities and communities is a precursor for control and elimination of malaria. I still say again, malaria remains the leading cause of death. And globally, Uganda is doing badly. And we all know that malaria is really a disease prevalent among the very poor because of the way it is. You can see, according to the Malaria Indicator Survey of 2019, West Nile had a prevalence of 22%, way above the national, which was 9%, though Karamoja was the worst. Yeah, but there are interventions. There's something you've gone ahead so fast. Yeah. So that's what I was saying. We're not doing well, West Nile. So let's go down. PICOT, my organization, with the support from Global Fund through TASO, has been handling mainly ICCM. And I should face this side, eh? Yes. Then it can sound, eh? Okay, it's alright. Okay, let me be like this. So ICCM is what we implement, and we are saying integration of malaria services within ICCM is essential for malaria what? Elimination. You can go down. Like I said, there have been some challenges. That's why the prevalence of malaria was high. And we had a weak health facility and community systems. We had a weak because there were issues of inadequate funding, the issues of stockouts of drugs, the issues of VHTs not being supported, no dialogues taking place to influence behavior change. Now, in August last year, PICOT started a project that aimed at bridging those gaps. And that was through supporting the district health management team so that they're able to do support supervision. Yeah. Now, just briefly about PICOT. PICOT is an NGO. It operates in West Nile in 6 districts. Those are the 6 you can see. Now, PICOT handles many things. There is livelihood, there is health, community health promotion, among others. Now, when PICOT received funding from TASO, let's go down. they started supporting those districts. And these districts, there are 5. As I had said, we can proceed. Now, those are the health facilities we've gone to, and those are the VHTs we have worked with in the region. You can see there's Arua, City, Koboko, Maracha, Yumbe. And you can see we have 105 health facilities we worked with, and about 6,000 VHTs we have worked with. So we can go to the next. Now, how are we reaching to these facilities? We would use DHS2 to get the high burdened sub-counties. We would get up to 10 sub-counties, we identify them. From DHS2, we can look at the malaria, the OPD attendance due to malaria. We can look at deaths due to malaria, inpatient deaths due to malaria. So that is for us to identify the sub-counties that we need to prioritize. So what happens is that after we've identified these facilities, the district health management team, well composed, multidisciplinary, because you can have the DHO there, you can have the malaria focal person there, you can have the biostat, you can have the medicines and the medicine supervisor there, then they go to these facilities. So they are normally informed about the visit, and then schedules are made.
Refugees in Uganda, and as of 2024 we had 1.7 million refugees, and of those 8.6 are urban refugees, with a category like with 27% of the 8.6 being 15 to 24. So we did not have a disaggregated data specifically on adolescents, so we just compounded them into that specific figure. So the focus on urban adolescents is because a lot of work has been done on refugees who are living in camps, but there is not so much on urban refugees that has been done. And we all know that urbanization is linked to a number of challenges, and young people, specifically adolescents, they face multiple forms of victimization, which we call poly-victimization, which is brought about by urbanization. And as we shall see in the subsequent slide, why the focus is because we have a section of urban refugees, but our current legal framework and focus on refugees is mainly prioritizing those who are in camps as opposed to the urban refugees. So you realize that adolescents have very little agency and bodily autonomy, because even with the host country as Uganda, we all know that adolescents have issues in accessing contraceptives, right? But for refugees, there is an added layer of being a refugee, which also compounds their issues in terms of accessing contraceptives. And we know that we have an open door refugee policy. We keep on welcoming, but in terms of welcoming, we do not have capacity to actually support their SRHR needs. Uganda runs an integrated refugee response plan, whereby, especially in urban areas and also in other host communities, the refugees use same access points as us as the host. So, I have a lot of information, but given the time, I'm trying to see the relevance that I can be able to highlight. So as I had put it right, that because this conference is about social determinants, so this particular paper looks at how different social determinants shape adolescents' access to contraceptives, especially adolescent refugees who are in urban areas. And it's grounded in international human rights law, international humanitarian law. And without further ado, this was the methodology. As I said, it was an academic paper that was written, and it's going to be published, hopefully by the end of this year. And it was more of a secondary research that was grounded into reproductive justice and intersectionality. So these are some of the key outcomes that the paper highlighted, that there are 4
accessing contraceptive services. We have at individual level, and we are looking at factors such as age, whereby like this particular age group is more vulnerable and they have limited access to contraceptives as opposed to those aged 20 and above. We have levels of SRHR knowledge that's also influencing. We have levels of education as also being a key determinant, and also marital status, whereby the unmarried ones are having more problems accessing contraceptives as compared to the unmarried ones, as compared to the married ones. We have layers at community level as well, and these are shaped by both the host community as well as the community of origin, and it shows that issues like religion, culture, gender norms are all influencing access to contraceptives.
You just have 2 minutes remaining.
Okay. Also, the other layer is at institutional level, and at institutional level, we are looking at the triple AQ framework. If you've interacted with the human rights law, you know that the triple AQ framework in access to health was established by the Economic Committee, the Committee on Economic, Social, and Cultural Rights, and it shows that there has to be accessibility, acceptability, availability, and the quality of services. And in the triple AQ framework, I will just focus on one thing, on information accessibility. The biggest issue I found out was the issue of language barrier, because most of the urban refugees speak Swahili, they speak French, and they are not well conversant with the Luganda and English, yet most of our facilities provide services in those languages. So language barriers was one of the key issues that came out, and also, okay, I'll just go to the legal and policy framework since I have 1 minute. I looked at the Refugee Act of 2006, and it actually prioritizes, it discourages refugees from leaving camps and settling in urban areas. So priority in providing services goes to those who are in camps. So if you go to urban areas, you're basically on your own. So most of them use out-of-pocket expenditures to meet their SRHR needs, including contraceptives. So that's a huge barrier, especially for adolescent girls, and it somehow pushes them to multiple forms of violence to be able to meet the out-of-pocket needs for their SRHR services. So I had quite a lot, but
just give you 1 more minute.
Okay. Okay, to conclude is that one of, like, there were quite many lessons that were learned from this academic paper. As stipulated here is that our integrated approach may not really be working in terms of meeting the contraceptive needs of urban refugees, especially adolescent girls. I also looked at the issue of the Refugee Act prioritizing encamped refugees as opposed to urban refugees. They could be an issue that we need to pay attention to. And also the issue of out-of-pocket expenditure, we really need to pay attention to that. So this is the relevance of the research, and these are the recommendations that we researched. The research paper is quite long, but this is just an overview of it.
Yes, thank you very much. Let's do the next presenter. Ojandu, is she with us? No, she's not. Oh, so we'll have some more minutes later. Yes, the third presenter is Wangira Edwin. Wangira Edwin will be talking about advancing SRHR among marginalized adolescent girls and young women in Namaingo district. The floor is yours, please.
Yeah, thank you. My name is Wangira Edwin. I'm a educator from Namaingo district, and I want to present an abstract entitled Advancing Sexual and Reproductive Health and Rights among Marginalized Adolescent Girls and Younger Women in Namaingo district, and the role of peer education. The Stand Up for Sexual Reproductive Health and Rights project, funded by Oxfam Uganda and implemented by SEHAD, FEMFORD, and Reproductive Health, is focused on advancing the realization of sexual and reproductive health and rights by major marginalized and vulnerable right holders in Namayingo district. The background content of it is that the project recognized the influence of young people on their peers and how peer-led interventions are increasing knowledge for the potential to foster positive health behaviors and enhance access to SRHR services. This approach leverages the authenticity of individuals within their communities to promote improved health and human rights outcomes in a culturally sensitive and age-appropriate manner. And the other methodology, young people, passionate and committed individuals with influence in their local languages, are identified and trained, equipped with vital knowledge on SRHR, access to justice, and community mobilization. The peer educators also lead young people to health facilities and report sexual violations and to authorities to advocate for young people. And they also engage the youth through dialogues, football tournaments, and sensitization sessions, linking them to health services and cultural practices. Peer educators have been instrumental in mobilizing young people to access health services and information. They successfully increase young people's access to SRHR information and services, boosting antenatal care. When we talk about boosting antenatal care, like I said earlier during my first presentation, for us as peer educators in Namayingo district, it is our task to move around the health facilities to talk to those pregnant mothers on how best they can attend their ANC. And they usually practice it. And we also, as educators, strengthen the referral pathway. The lessons that we can learn, I'm trying to rush because of time, the moderator is telling me I have 1 minute or two, is that empowering peer educators can significantly amplify the impact of SRHR initiatives. Peer educators serve as vital conduits for disseminating information, addressing misconceptions. For us in our rural areas, there are a lot of misconceptions, like on family planning. People in our rural areas have always been quoted in the way that when someone uses family planning, the chances of delivering a child with a disability, more so the hydrocephalus, are very high. Some young girls have also put it in their heads that when someone plays sex, more so when a girl plays sex while standing, she can't conceive. So they have been quoting those particular things, and as peer educators, we try to give them light and show them that no, this can happen even if it is done in this manner.
And can you conclude this?
Yes, as I conclude, in my recommendation, I can only say, for a sustainable strategy to enhance SRHR in Namayingo, increased investment in education program is needed, deepen comprehensive sexuality education for young people, integrate economic empowerment, then strengthen youth-friendly services. I thank you all.
Thank you very much. Yeah, actually, let me just emphasize that the findings of the presentation are posted in the conference book and will be shared by all participants. So, by so saying, I think I would really request the panelists or the presenter to be like very short and straightforward. We'll be given 3 minutes, per presenter. So please, let's move to the next one. Who is Nabunya Gloria? Nabunya Gloria will talk about the cost of limited sexual education. Please take the floor.
Hello everyone.
Hi.
You look bored and tired, are you? So how many of us have, please? No, it's okay, it's not much, I will do this. How many of us have parents, have children in this room? How many of us have talked to them anything about sexuality education? How many of us have not? You can raise your hands. It's okay. Yes, thank you. Who is talking to your children for you? So my name is Gloria Nabunya, and I am the founder of Together Against Childhood Sexual Violence Uganda. My topic is clear: the cost of limited sexuality education. How ignorance fuels childhood sexual violence in Uganda. Now I'll start with an example from the field, from a survivor of childhood sexual violence. She said, we had a party at home, and one of my brother's friends, while we were dancing in the evening, he tried putting his finger inside my vagina. When he tried putting his finger inside my vagina, I tried stopping him. After like 30 minutes, he came back to me. He told me, you are a rock, you're not a woman. I'm going to tell the entire village that you do not have a hole, women are supposed to have a hole. So she was scared. She didn't know who to talk to. She was scared of her mother because her mother is very tough. And after she told me when she went back home, since she was scared during holidays, since she was scared that he was going to publicize to the entire village, she chose to go to him to help her create the hole a woman is supposed to have. Now, most of the times when we talk about sexuality education and childhood sexual violence, people think that it is limited to rape. No, it is not limited. It's not limited to rape. Our children are sexually abused because they do not know. Now, when you look at our findings and our study, we did a study in 2024. Even now, we are still on the study. We did not do it in the digital way, but we did it in the manual way, with papers, because we do not have the resources to enable us the other way. But when you look at our statistics in Uganda, in 2024, according to the 2024 Uganda Police Report, we had over 12,312 cases of childhood sexual violence. Now this is too much, although other cases were not covered. According to the survey we did, you'll find that we did a survey in 20 households and in 3 schools. Now in this, we did a survey on 150 survivors of childhood sexual violence. It is unfortunate that it is very easy to find survivors of childhood sexual violence. By you moving out here and engaging with a child or with an adult, you'll find that they survived. They were sexually abused. And sexual abuse that is not limited to penetration. Sexual abuse can be bad touches. Sexual abuse can be language. Sexual abuse can be online, So going to the online findings, please you can go down. Going to the online, yes, thank you very much. Online findings by EPAT International. I made sure I involved other studies because I'm not the only one, and we are not the first people to do a study on sexuality education. There are people that have done studies, just that the data is limited. Now, I do not know if you people have heard of internet safety or any online sexuality education, but as you can see, the world is going digital. Yes, thank you. As you can see, the world is going digital, and while the world goes digital, children are being sexually abused online. Now, ECPAT did a study, please you can slow down. And according to the study they did in Uganda, only 35%, mostly all the children aged 14 to 17, reported having received information on how to use the internet safely. Now I can tell you I was seated next to Miss Angela from the Ministry of Education, and I asked her, you people are drafting a new framework, yet we had an old one. We did not even try to implement the old one, but now we are having a new one, which is health education and whatever. And I was like, have you considered it being online, like the online sexuality education? Do we have anything like that? And no, she said we've not thought about that, something to think about. Now, we found that even children that received even the smallest information about sexuality education, they can say no. We found that whenever parents ignore sharing this information with children, they ignore communicating with children in relation to this sexuality education, children can go on and engage in sexual activity, thinking it is okay, thinking it is this, thinking it is what boyfriend and girlfriend do. And remember, child sexual violence is not only adult child, but it's also child to child. Now, Together Against Child Sexual Violence Uganda is doing something in the communities, because when we found this, we couldn't keep quiet. Yes, I'm concluding. Just 1 minute, please, if it's okay.
Okay, just conclude.
Okay, thank you. So what we do, we have a campaign running in schools called "You Have a Right to Say No." We are reminding children that it is okay to abstain from sex. There is beauty in that. There is dignity in that. And we provide intentional sexuality education to the children. Then we also have the Survivors Choto. Survivors Choto is a youth safe space for survivors of childhood sexual violence, where we gather, we share our stories. These stories inform us, so that when we go to children, we know the tricks of perpetrators. We know what they tell our children. We know how they lie to them, you know. So the other program we're having Parenting Beyond Survival, which then runs and turns to parenting as a community. Survivors of childhood sexual violence most of the times don't have the knowledge to parent a child. They're children. A child cannot parent a child, you know. So what we do is we provide the parenting skills, positive parenting skills to these children. And I want to thank the government of Uganda and the Ministry of Gender for offering the parenting course, the evidence-based, the science of designing evidence-based parenting course for free at Makerere University. I went there and I learned to design a parenting program, of which I did. So thank you very much.
All right, thank you very much. Yes, I think a very critical question from Namunya is that if you are not talking to your children about sexuality education, who is doing it for you? That's really a big question each of us should ask himself and herself. Yes, let's move to the next presenter, who is Nabwile Pauline. Nabwile Pauline from Family Medical Point will be talking about reducing unsafe abortion among women and girls in underserved. Please.
Hello.
3 minutes.
Good evening, everyone. My name is Nabwile Pauline, Head of Programs at Family Medical Point. I made some, yeah, that's the right title. Our abstract is about really sharing our experiences as Family Medical Point and what we have done to reduce unsafe abortions among women and girls in fishing communities. Unsafe abortions are not just a medical issue. They are socially driven by systemic inequalities. For example, girls and women lacking the financial resources to access modern contraceptives, having limited awareness about their reproductive rights, having limited awareness about their reproductive rights or where to get these sexual reproductive health services from. This leads to unplanned pregnancies and eventually unsafe abortions. Unsafe abortions are still contributing to maternal mortality and morbidity among women and girls in these underserved communities. These communities, because they are usually isolated, the people in these communities have limited access to sexual reproductive health information. The stigma and restrictive laws also contribute to some of these challenges. Family Medical Point is addressing these challenges through our community-driven strategies, which I'll be sharing with you today. For example, our Musawa session. Our Musawa sessions are our health talks, which are safe spaces where trained community peer mobilizers, who are peers of these girls and women in these communities, go and educate their peers and share with them sexual reproductive health knowledge and information, and also link these peers to quality services in these communities. In some of our community-driven strategies, we also build the capacity of the community health workers. These community health workers are based in these landing sites, and I'll share an example of, for example, Chikungu landing site. For those
default means of transport from Chibungu to Entebbe is boda and maybe airplanes. So the only thing that people can really afford is probably boda. So this makes it hard for these people to access the quality services that they need from Entebbe. So we build the capacity of these health workers to be able to provide quality sexually productive health services. We provide them with equipment like MVA kits, couches, autoclaves, to be able to provide these services without these people having to move far distances that they can't probably afford. And then we all know that people listen to the media. So what the media says, people listen. We have been partnering with local media, built their capacity, transformed their attitudes to be able to report accurately about sexual reproductive health issues. And this has been able to promote accurate reporting about sexual reproductive health issues among journalists that have in Uganda. Yeah, those are some of our results. We have over 20,000 individuals in these fishing communities have been able to access sexual reproductive health services and information and family planning, as you can see those numbers. So as Family Medical Point, we still believe that if we continue to engage the media, because currently, as a trend, many people are listening to the media, the local media, social media, digital. If we engage the media, we are going to be able to bring out or speak for the people who are in those communities and share their challenges more accurately. And then we shall, if we also continue to engage the communities through the peers, as CSOs here and some government officials, if we continue to engage the communities through their peers, we are going to be able to reach a bigger number of people and give them accurate information about sexual reproductive health and rights. And then also continuing to build the capacity of our health workers to be able to provide quality sexual reproductive health services. Thank you.
Thank you so much, Namire. And I think in your presentation you emphasized, the importance of engaging media to break the silence around unsafe abortion. It also talked about community-private strategies, which really try to break stigma and silence around all of these issues. Thank you very much for that. Let's move to the last one, and this one is Hope. We'll be talking about the impact of empowering programs on adolescent girls. Please, 3 minutes.
Okay, thank you very much. Good evening, everyone. My name is Hope Akim, and I work with the Mentoring and Empowerment Program for Young Women. I work as the advocacy officer. My presentation is on the impact of the empowerment programs on adolescent girls and young women's uptake of SRHR services in Greater Nairobi District. I'm here basically to share our experiences on how we have utilized the social survival skills training approach or model. It's one of our empowerment model or approach that we've utilized for the last 16 years. I basically would like to just summarize what this approach is all about. Thank you. So this approach, or if I would put it as a model, targets adolescent girls and young women in schools and even out of school. We take them through a 10 days training on social survival skills, basically. The component or the key component of this model includes life skills training. Here we train them on, we give them basic information about their bodies, the changes that they are going through and how they can embrace that. We also inform them about risky behaviors such as, behaviors that can make them get pregnant and drop out of school, basic skills like decision making, assertiveness, confidence, so that they are able to navigate the different issues that they face. Apart from that, we also do awareness creation and community dialogues. Now, this is meant to create environment where these girls are able to seek help from the health facilities, from their parents, from their teachers. Oh, I forgot to say that this training also targets teachers in schools. So as we train the girls, as we train the boys also, we also target the teachers so that they are able to support these girls to navigate the different developmental challenges that they are undergoing. We also train them through peer support or mentorship. Having taken them through all this, they are able to also support the younger ones about how to manage their menstrual hygiene, how to support those who are probably being swayed off by different risky behaviors and things like that. Now, one thing that I would like to say that as all this is going, the other component that I should not leave out is the SRHR information, ensuring that we give them accurate information and demystify the myths and misconceptions that are there in the community about reproductive health, the stigmas that exist about reproductive health and accessing and taking reproductive health services in the community. So as all this is happening in this approach, we also provide like individual counseling designed to support them to probably heal through some of the things that they've already maybe experienced. Some of them have already been sexually abused. So we take them through that counseling session to help them to heal and then take a different path. So basically, let me share the lessons. The lessons that we have learned that I would like to share with you here through this approach that we've taken for all these years. We've learned that empowerment is a key thing to SRHR uptake. When people are empowered, when people know where to access services, when these girls know what to do, there is no one that can play around with them. Remember, I talked about building their confidence to say no, making them building their decision-making skills so that they are able to know what is right and what is wrong, but also putting around them good support of teachers and fellow students who are able to mentor them and take them through some of the challenges that they are facing. So the other thing is that peer support sustains change. When you train and build that network, people are able to support one another. We've had several stories and testimonies that I may not be able to share here of how our peer, how the students have been able to help fellow students when they are almost at the verge of landing themselves into problems. And then the other thing is that community engagement reduces stigma. There's a lot of stigma related to accessing SRHR or uptake of SRHR. Okay, well, okay, let me just share the challenges. Now, all this, like I said, we've done this for the last 16 years, but we've also had a number of challenges, and one of them has been the deep-rooted negative cultural norms. I will not go into the explanation, but also stigma and the rest, misinformation and others. So I would like to conclude. I've written down my conclusion. I would like to conclude in this way, that social survival skills training is an empowerment approach that has been adopted by MEPRO for over 16 years, and it has had a significant impact on the uptake of SRHR services among adolescent girls and young women in West Nile region. We've done this through awareness creation, building self-esteem, challenging negative cultural and social norms that hinder SRHR services, among others. Thank you very much. When you begin to remind me of time, I get nervous, but I think I've passed across the model that we've been using. Thank you.
Thank you very much for just concluding. Yes, I think for the sake of the time, we will allow a very few intervention or very few reaction from the audience. And now I think we'll allow only 3. this one, we'll move to that one.
A team leader for Positive Women with Disabilities Uganda. It is a network of women and young women with disabilities dealing with HIV. My concern cross-cuts to all presenters. The issue of women and young women with disabilities is not coming out here. We know that women and young women with disabilities, for example, when it comes to menstrual hygiene, we have those ones who are deaf, we have those ones with maybe the hand, they have no hands, maybe we have the deaf community. And we know they are there in Namaringo, they are there in our communities. How do we engage them? Because they are the most vulnerable population in our communities. How do we engage their parents and caretakers for the issues of SR, HR issues? Because of him, I beg to stop here. Thank you.
Yes.
Which hands did you allow?
Which of you could?
No, they can probably respond after. Which hands did you allow?
There's something you said about language barrier. My suggestion is, I don't know, maybe you react to a suggestion, but I worked with Refugee Law Project for some time, and it had refugees from like South Sudan and all that. And remember, in Uganda, it's not very easy for people to understand those South Sudanese languages. So we had to meet in the middle, and they had a program where they would teach people how to, like, basic English. So they would have like people going to the refugee settlements to teach like basic English classes. So that helps to bridge the gap of language barrier a bit. It takes time, but I feel like at some point you have a middle ground. So maybe that could be like a solution or something like that.
Alright, thank you. I saw a man somewhere.
We are advocates for safe abortion services having concern around public health facilities which are implementing some projects from SA that have signed a commitment prohibiting them to offer any abortion-related services. So my question to Pauline is, how are you going about that? Because so many people are asking for safe abortion services. Thank you.
All the presenters for emphasizing the issue of capacity enhancement and strengthening the community members, so that instead of us as actors all the time being in the community to be there to do it for them, you are doing a great job by supporting them so that they are able to do it for themselves. Even when tomorrow you are not there, they will be able to do it. So I would like to encourage everybody in the room. For me, that was actually very key, and I think that is the direction to take, whereby whatever we do it like tomorrow we are not going to be there, so that even when we have left, the community can be able to address the challenges faced within their community, so that all the time they don't wait for us. Thank you.
All right. The last lady.
Gentlemen and others, if you're in the room. My name is Enimo Brian. I serve with the Uganda Network on Law, Ethics and HIV, Uganet for short. I've been discussing with my sister here from another mother on where the men come into this SRHR conversation. Believe me, SRHR conversations have had more of a female face, and you can look around in the house. The men are either here because they work in that space. But for me today, I came to owe that girlfriend called SRHR, understand her, and see how best I can win her to myself. Because tomorrow I'll be a father, but this doesn't just stop at women alone. I think speakers on the podium help us understand where do the men step in to support this agenda. And secondly, to reinforce what Betty said about PWDs, I, for one, am visually impaired. But if you look at the gender cross just giving them, I'm expounding on Betty's point, because I think it's important to look at these children with disabilities, these girls down there that don't just suffer the pinch more climbing to the hierarchy. But my question is, where do the men step into this conversation of SRHR? Thank you.
Thank you.
People with disabilities. Oh yeah, thank you, Madam Betty. Providing sexual reproductive health services, and they are in need of sexual reproductive health services. They are a priority. So yeah, we cater for them. I do not know about the rest and my colleagues, but yeah, I believe it is an important part to consider in our work. So maybe I'll take also this opportunity to respond to Ronald. In the interest of time, I think I'll just, I don't know if I got the question right, but then I'll only say we have been advocating for the amendment of the Penal Code Act to expand circumstances in which self-abortion can be administered. And as we continue to advocate for this, we are making some progress, because the last I checked, the PAC guidelines were approved. Until we get some positive response about the amendment and maybe circumstances in which self-abortion can be legalized in this country, I advise that whoever seeks for self-abortion services, please first get legal support from our partners. We have very many organizations here that offer legal support, so that they can advise in which circumstances someone can actually access self-abortion, and also continue to promote the prevention and then harm reduction, and also let us continue to give support to people in need of post-abortion care, because post-abortion care is a service that is legal in Uganda. So as we continue to, with our advocacy, let's continue to seek legal guidance. Yeah, thank you, Ronnie. I don't know if I've really responded.
Yes, where is the place of men? I think that's the question. Do you want to answer that question? Please, go ahead.
Yeah, thank you. My brother asked where men are involved within these SRHR issues. For us as educators in our respective areas, first and foremost, I want to tell you that we are both male and female. You see me, I'm a male, and they are my fellow educators who are female. So we are doing this work jointly. And as men, we usually target those places where our fellow youths converge. Like say the ghetto places, the pool centers, the ludo points. We share with them information, and at times we even give them condoms as a preventive measure. So we totally involve them. One moment will also allow me to talk about the issue of the PWDs. Yes, we have always prioritized PWDs. We first of all identify them and their location. We then use the door-to-door technique, visit them in their places, their homes of residence. We share with them this necessary information. We can't go away from their homes when they are totally informed. So we have not left them out. They are part of the program, and we always involve them. Then finally, my brother talked of capacity building. For us as educators, we are trained to train. In other words, we are changing agents. The people who trained us told us that we should also go back to our respective areas of residence, and we also train our fellows. So those whom we also train, they do a very big task in helping us to disseminate the good information, more so on issues of SRHR. Thank you.
All right, thank you very much. Number there was a suggestion regarding the refugees. Please.
Yes, I just wanted to respond to the issue of menstrual hygiene for children with disability. Well, in our approach, we've always prioritized girls with disability in the different cohorts that we have trained.
every project to bring them on board. Now, on the last question that you raised about where the men are, I would like to inform you and even other people right here that true, some men are not involved, or even most men are not involved, but there is a way men can be involved. Yes, that is through parenting. We're reminding ourselves that a child is not only raised by a mother, but by also a father. We're reminding ourselves that we all have a role to play, makes the men involved. Now, men can be involved, like she said, from the grassroots. If in our nurturing ways, as women, as men, we remind these boys that, you know what, this is your responsibility, your health is your responsibility. Your sister is your responsibility. This is like your meals, the meals that you eat. You don't just have to eat your commando, you don't just have to do this. I think there is a way, and I can really see that men that have been involved in the parenting programs have really changed. When you go back to those homes, women are saying different things. You know what? He's carried.
Thank
you.
you.
Know what? He goes to the hospital with me. Thank you very much.
Thank you so much. Yes, I think we shall have a wider discussion, after the next session on HIV treatment. For the sake of the time, let me thank you, all the panelists, for the great work you are doing and the very powerful strategies you have shared in trying to address social determinant of reproductive health. And those determinants are at very different level, individual, institutional, legal, and all this. So I think the work you're doing is really great, and let's keep it up so that we can really support the access to sexual and reproductive health by addressing those social determinants. By so saying, thank you again, thank you the audience for engaging us and for being passionate with all of us. Now, just to finish, I will ask a photo with my panelists. There's no photography. You can just use even the camera.
Quickly, you can stand up and thank you once again. Let's appreciate them. They have really tried in the time. They have really tried. Thank you so much. The photography, please. Yes. Okay, thank you so much. Let's appreciate the moderator, Mr. Nondo. Thank you so much.
Dr. Adrian Chivumbi, Dr. Martha Ajilong, and Gloria Nawanyanga. Please come to the stage. My name is Lilian Moreko. I work with the International Community of Women Living with HIV in Eastern Africa, and I'll be moderating this session. So this is a workshop, and we shall be looking at or talking about moving from the lab to the last mile. As you probably know, we are towards the last mile, which we may realize or not realize. Thank you very much, my panel. And we are going to be talking about learning. My panel, this will talk about it in full. I don't want to be speaking about something that sometimes it is very hard to say the Nakapafi, but that's the name. And here we are talking about the new child on the block in terms of Mukama. Dr. Gan, tell us about yourself, and as you introduce yourself, also talk to us about what you see as your role as a coordinating entity, specifically in terms of policy changes, of programmatic adaptations that are needed to effectively
integrate a long-acting injectable. But also, since you're a doctor, I'm going to request you that for the benefit of us who are not doctors, talk to us about LEN, what it is, and how does it work. Dr. Dan, over to you.
Thank you, Greta. Good evening, ladies and gentlemen. I am Dr. Dan Demkama. I work in Uganda AIDS Commission. Uganda AIDS Commission is the overall coordinating agency for the national HIV response. And I work as the head of HIV prevention. As the moderator already introduced, the Renacapavir that we are discussing today in Uganda is for HIV prevention, which is different from the regular treatment. So it's for primary prevention. And it works by inhibiting the attachment, the infection of HIV once someone is exposed through various mechanisms. It attacks the HIV virus that has entered the body at various stages, but stop its infection of the body cells. As the Uganda AIDS Commission, I must say we were excited about the invention of Lenacapavir and the promise it gives. The reason for quite some time we had stagnated in the HIV prevention. We had stagnated in our journey towards our goals and our targets. I can give you an example. The number of HIV usually done by the Ministry of Health Pharmacy Department, and I'm told one of the pharmacists, one of the pharmacists from the Ministry of Health should be able to tell us what is already in place. We look to updating guidelines. It's difficult to implement without national guidelines and protocols. There is training of staff on the use of lenacapavir. We were also considering good enough piloting the implementation from research. The effectiveness of lenacapavir was implemented, was demonstrated in the research setting. But we are lucky during the end, several stakeholders have made applications to pilot implementation of lenacapavir in various settings, in the private sector, where most of the at-risk people are likely going to access services. So there is also implementation research for us to model how a real life implementation will look like, and we are thankful to Unite that several stakeholders have applied for funding, and we look to learn from what they have. But as government, we have a position that we cannot wait for implementation research. We shall start implementation of this program, and findings from implementation research should inform how we perfect our implementation as we go. We are looking at capacity building, as I said, targeting the high burden districts at first. We shall have to discuss tomorrow which are those districts, which population groups are the benefits first, and the national population should come agreement. And tomorrow will be the first sector stakeholder engagement to agree that we all have a role to play, from civil society to private sector to development partners to government public institutions, agree that we each have a role to play, and we shall have to divide and find the roles tomorrow at our national population meeting, including stakeholder engagement. How do we go out to the community to get demand, to mobilize stakeholders? There is bound to be sabotage, which is already there, because there was bad publicity with the COVID-19 vaccination. So we expect some resistance in the community. So it's important that we prepare appropriately so that this product is maximally utilized. It is unlike the previous PrEP products. Lessons learned from the previous rollout of previous PrEP products, including oral PrEP, cabotegravir, shows that we need to be more proactive. We cannot leave these things to either the donor or to chance. We have mobilized stakeholders to make sure we are in charge, and I hope we shall agree tomorrow on which sites to do, to go to first, how do we do site readiness and accreditation of centers. So all those processes still stand in our way between approval and making this peer and service available to the people, but we hope we shall devise ways of extracting all those steps that are important for government. Thank you.
Thank you very much, Dr. Dan, for setting the stage, but also taking us deeper into the conversation that we are going to have. And that helps me because my next panelists, will try to be brief because most of the things you've talked about them. So next, I'll now go to Dr. Martha Ajiron, because Dan mentioned you, and I want to make sure that you take it up from there as a commissioner for pharmaceutical supply chain and logistics in the Ministry of Health. So from your perspective and from what Dr. Dan is saying as Uganda's commission, how will the Ministry of Health regulate and procure land, but also work around processes that are streamlined to ensure that it is timely, efficient, but also importantly around approvals? How do you see that happen, and how do you want to fast track that, well knowing that WHO has already given us a go-ahead? Dr. Dan is saying they are ready tomorrow to come up with a roadmap as the prevention committee. So how about the ministry? Please talk to us.
Thank you very much, moderator. Land is used for prophylaxis for people who are at risk of getting HIV. As Dan has already said, it was WHO gave us the guidance to use learn for pre-exposure prophylaxis. And as the Minister of Health, we have already quantified for around 18,470 clients, and we expect to get lenacapavir in country by March 2026. And with the support from the Global Fund, at a cost of around $60, we shall be able to get one commodities worth around $1.1 million US. So what are we doing now? We are developing guidelines and a rollout plan for lenacapavir. And also we are in the process of registering it with the National Drug Authority so that when the commodity comes into country, it's already registered. Thank you.
Thank you so much. I'm sure you're hearing the plan. There has to be approvals, we have to have guidelines in place for LEN to be used. But she's also telling us that we shouldn't expect it this year. It may be 2026. And later on I'll be asking Gloria to talk to us about that, but also from your perspective where you're seated, how you see that. So our next speaker is Dr. Adrian Chifumi. You've heard from the coordinating entity for HIV. We've heard from the ministry giving us a roadmap. And from Uganda Manufacturers Association point of view, and from an industry perspective, what are the key opportunities and challenges for local pharmaceutical manufacturers to eventually produce them or similar long-acting HIV treatments, and what support would be required from the government and international partners to make this a reality? What kind of partnerships do you think we need to have with you? Thank you.
Thank you very much. Here we live in two capacities. One as the Secretary General for Uganda Pharmaceutical Manufacturers Association, whereby this question really relies on the interests of all manufacturers in regards to what policy frameworks do we have in place to support local manufacturing of lenacapavir and other antiretroviral drugs. And on behalf of DEI Biopharma Limited, which is the company that looks forward to making this drug locally, where I'm the executive manager for business development, looking at the impact and the realization of this comes from two areas, which one of them government has already worked on, regarding the supportive framework under the TRIPS agreement, where our laws actually in Uganda enable us to develop locally innovative products and be able only to use them within the jurisdiction of Uganda. And also looking at the innovator having done clinical trials in Uganda, so we are more of a case study that already has attributable data that ascertains to the effectiveness of this product or this drug. So even if locally made, we have some data to start with, given the reference of clinical trials that were performed. So going forward, without a good licensure framework, there cannot be a good roadmap to incentivize the introduction of this drug. But looking at what we have as Uganda, we have a fast-track system that enables local manufacturers to be able to roll out a new product within close to 6 months. So to any investor looking to assist a local manufacturer in bringing
so much. So, for those of you who are like me, who did not study these subjects, I think they are talking about demand and supply. And I think Doctor is answering to Dr. Dan's question, who do we start with? So he's raising the question of, we have demand. Is there demand? If they supply it, would then have a market. But then I'm also remembering that the Prime Minister reminded us that we have 73% of the population in this country as young people. And therefore, but also I'm remembering that we are having a crisis of resources, Dr. Dan, that we need to prevent so that we are able to sustain the gains that we have made. And therefore, we need to work together to make sure that we create demand, they are ready to provide, that is supply, and the ministry is already working on the roadmap in terms of how we get to land here. But we need to work together as partners. We need to create partnerships. And that's how and where Brodia comes in. But I think there could be some issues that we need to be addressing, even when everything seems to be rosy. So Brodia, from a young person's perspective, an advocate, an activist, what do you see as the most significant real-world barriers that young people that we are talking about, who may be the beneficiaries of them, face or will face in terms of access and adherence? He has already talked about some of the issues, but from a young person's perspective.
Thank you so much. Good evening, ladies and gentlemen. Good evening, ladies and gentlemen. That's better. My name is Nawanyaga Gloria. I am a global HIV advocate, a young person living publicly with HIV. I am the founder of Gilo Young Posters Foundation, which is a youth-led charity organization where we do empower, equip, and educate young people to improve their livelihoods. I'm also the Global Alliance Committee champion to ending AIDS in children and an aspiring youth MP Central Region. I'm so much delighted to be here on this panel tonight, and I'm just going to dive into the question right away. On behalf of young people, speaking on behalf of young people, we are facing so many challenges, and just like the Prime Minister said, Uganda is one of the countries with one of the youngest populations, almost 73%. They are young people, and these challenges are actually continuous. So I'm going to categorize these challenges into three. We have structural barriers and challenges, we have social and cultural barriers, and then we also have individual level barriers. Under structural barriers, we have limited access, first of all, to clinics and treatment as well. You can agree with me that in Uganda here, we still have people who cannot access health facilities because of the long distances, because of the limited health facilities in that particular region. And we find some of them have to trek long distances to go and access this treatment. And this is a big challenge, by the way, because it limits people to go and get these services. But then also when it comes to, for us, as I introduced myself earlier, a person living with HIV, having my drug refill probably every 3 months, after 3 months, it becomes challenging because of the long distance that these facilities are. We also have the limited clinic visits. The fact that now, of course, I recommend that the integration, and I do really applaud Ministry of Health for bringing in the integration after the funding cuts. But realize that there are still overwhelming numbers in these facilities, and some young people actually have gotten complaints who go to facilities, and trust me, when you go to these, especially rural areas facilities, by around 1 p.m., most of the doctors and nurses are not in these facilities, agree with me or not. So imagine these facilities already have overwhelming numbers, and then they added patients on these numbers. So some people will not be able to get their treatment because they're already overwhelming numbers. By the time it clocks midday or 1 p.m., the doctors are nowhere to be seen. When they go for the lunch breaks, some of them don't even come back. And what happens? Young people end up missing their treatment. Young people end up being limited to the clinic visits. Lastly, under this high transport costs, I talked about the long distances, but then also some of them discrimination, agree with me or not, we still have stigma and discrimination in our communities, even as people live with HIV. And also, when it comes to access to PrEP, even those people who are living negatively with HIV, they are facing stigma and discrimination when they go to access this lenacapavir, the oral PrEP that we all know, because some people actually call them or think that they're HIV positive, and they end up stigmatizing them. And actually, some of them don't even take the medication when they get the oral PrEP. Some people say that they are taking ARVs, so they end up not taking the PrEP. So I can really, say that lenacapavir is a game changer for us as advocates, and it's really an achievement for us that I believe we should all applaud that with a hand clap. Yes, thank you so much. Then also under the individual level barriers, we have been having the oral PrEP, which is being taken daily. And as a person living with HIV, I can tell you it is hard to take medication every day. And just like I already tell young people living with HIV and those who are not living with HIV, protect yourselves. It is not easy to take medication every day. Even me right now, I'm still having challenges. But with lenacapavir, I'm glad. It's just 2 injections in a year, which is a very good achievement. But I can tell you that there have been challenges with the pill burden among young people. Lastly, mental health challenges, especially among young people. This has, caused so many young people not to come here, so many young people to live recklessly, going to drugs and all that, and they end up getting HIV, but then also not able to get these treatments that they need. As I conclude, I understand that, just like I said, we should applaud lenacapavir for prevention, but as an advocate and a young person living with HIV, I would also appreciate very much to have lenacapavir for treatment. We are tired of taking medication every day, and just like this is a milestone in prevention, we should also have this milestone in HIV treatment, that you can also get an injection which can be taken once or twice in a year, and we get rid of the pill burden that we take every day. Thank you so much.
Thank you so much, Gloria. I don't think we have a lot of time. I want to give my panelists concluding seconds, starting with Dr. Martha. How do you see where we are, and how do you think we should get where we want to get?
Thank you. We shall get there. As I already said, we have already planned for 18,470 doses, and we shall get these commodities by March 2026.
So we already have commitment from the ministry, and please also applaud Global Fund, especially our representatives on the CCM. I understand the Global Fund is giving us money. So we can have 1-2 people from the audience so that you don't feel we have sidelined you. We have 2 hands and that's it.
Thank you very much, our dear panelists. My name is Festo Majijaj from Southern Sub-Region, particularly Controller District. My question is, when I heard Dr. Gilom very well, the cost is about $60, and $60 is about 216,000 shillings, Ugandan money. And you heard from the manufacturer that, honestly speaking, that cost is way too high. I don't see a headway unless government makes a commitment to support local manufacturing, but also government makes a commitment to invest more resources in injectables, because those 14,000 doses is very small, because it's a PrEP, and once we encourage the citizens and galvanize demand, the supply may be short. But as civil society, we are committed to mobilize the communities, because the burden is ready. Thank you very much.
was going to Dan. We know that the uptake of these new innovations, the medicine, is basically driven by how we mobilize communities. I would like to hear the investment government is putting in to support civil society as we commit, to ensure that we mobilize communities. Next year is not so far. We need communities to be aware so that when we have the drug or the injectable, we are able to uptake these innovations. So what commitment are we putting in from the government perspective? Thank you so much. Dan, you'll be the last to speak. I would like to probably give it to Dr. Adrian, your parting words, but also you can respond to the questions that you had.
My parting words are quite simple, is that most of the times we tend to look at each other waiting for what one part will do, and we don't look at ourselves, that what can I do as a person. One key thing I can tell you that personally I'm proud of Ugandans, especially the manufacturers that I represent, because they have taken on the risk of investing close to $500 million of investments in the pharma sector in Uganda, even where markets are not guaranteed. That's our commitment. So in regards to what are they bringing out, this is also something we need to understand as communities, that what is our role to support them? Are we using their products? Do we spread the right and justified information on their products? Because it's another thing, one investor taking the bold initiative to roll out a product that is globally highly costly, and then people marginalize it in one way or another. So that means that we all have a role to play as citizens, as civil society, and as government in laying out the policy framework that is supportive, and also in bulk purchases. So my parting word is to all of us to understand that the goal of realizing this is an initiative that all of us have a role to play in it. Thank you very much.
Thank you. Gloria, a call to action.
Okay, thank you so much. My call to action is, as young people, since we are the largest population in Uganda, we should be prioritized. We should be meaningfully engaged, not only just hearing that there is the Nakapava, that I'm sure there's so many young people out there that don't know about it. Also brings me to the community preparedness, how we're going to educate the young people to make sure that they utilize these services, because they are for communities. So we should mobilize them, we should educate them, we should create awareness, but then also we should work in global solidarity, just like he has said, we all have a role to play. We should work together to see that, we achieve this goal. And lastly, we should put communities at the center. We should make sure that communities are also meaningfully engaged. Prevention is better than cure, but then also you should not forget about treatment. We have Lena Kapava for prevention. We need Lena Kapava for treatment as well. Thank you.
Thank you. And lastly, Dan, respond to the questions, but also to my area of focus, choice. How shall we, or how will you help us ensure that choice still remains on the agenda? That the pivoting vaginal ring, capotography, condoms, well knowing that we are different and we may have different choices.
Thank you. I think I'll start with what is the government putting into civil society. That's a hard question. Because knowing what is going on, when I listen to my colleague, the pharmacist from the Ministry of Health, we have budgeted for, Global Fund has committed to support us for slightly above 80,000 doses. From research, it took 40 doses, 40 person years being on treatment to prevent one infection. Put 40 people in a Kapaville for a year to prevent one infection. So when you look at the 80,000 we are budgeting for, that means at the end of the year, with all the efforts we shall have society. It is the young people like Gloria, it is the young people like Sister Immaculate who asked me the hard question. We need advocacy for meaningful investment and even advocacy for other things that are not well defined. Let us be clear the role of civil society. As I said in our meeting tomorrow, we intend to have a conversation and agree that this is a multi-sectoral effort. In the past, there has not been serious community mobilization and demand creation because you don't mobilize people for where you have one cake. You don't even say it, you only whisper. Those who come, they are the lucky ones. And it appears we're almost about to find ourselves in the same scenario. But we shall not accept this scenario. I call upon civil society, advocacy, start asking the hard question like Immaculate has asked for. This 450 is still not enough. It's not. We are still committed to choice because we know from time that the prevention needs of individuals are not the same. Someone wants a condom, someone has condoms that don't work for them. So we are committed to making choice. And that's the spirit in which we are moving in a Kapaville, Kabotagraville, all these products to make sure they are accessible because we have learned over time that the prevention needs of individuals differ. Create as many options as possible so that everybody gets to get what works for them. It's part of national policy. It's the drive behind making these products available, but I said meaningfully making these products, new innovations available, calls for advocacy. So my call to action is civil society stakeholders, young people, prepare to advocate. I don't know the tricks you use, but there is need for some noise to make sure there's meaningful investment in these products and prevention is taken seriously and nobody is left at the risk of contracting HIV.
Thank you so much. A big one for my panelists. And our final call to you guys here is that tomorrow and the day after, talk prevention, talk them, talk choice. Talk human rights, talk sexual reproductive health. We cannot talk about sexual reproductive health, we cannot talk about human rights if we don't talk about prevention. And with that, thank you very much for being a good audience. We cannot thank you enough for staying with us after 5 when everybody seemed to be going away. So thank you, and we wish you all the best in the remaining days of the conference. And to my panelists, thank you very much. Dan, we wish you the best tomorrow in the ministry. We shall come to you to make sure that we increase the numbers, because numbers matter. Thank you.
Thank you very much. Our panel moderator, there should be a group photo for this special panel that has been discussing serious matters. And I'm glad my boss is here, so any questions to do with the supply chain of medicines, you know that we are covered. Thank you very much. Commissioner Reproductive Health, Dr. Mugai, we recognize your resilience. Thank you for speaking with us. And tomorrow we start at 8:30 sharp.